my time starts. Good morning, everybody. Respected seniors, colleagues, teachers. Thank you, Dr. Deepak Nandan, for that excellent, persuasive talk on the qualities of Empagliflozin. I'm sure, similar to my state, everybody in this room is now almost on the verge of switching over to Empagliflozin. I would just like to put forth my points. Yeah, so am I switching my patients to Empagliflozin? These are a few articles which came over the past few months about Empagliflozin. And we know that these are not scientific journals, but this is from the Hindu, the Economic Times. It is obvious that there is a marketing storm around Empagliflozin. So as clinicians, should we get caught in this marketing storm, or will we be able to hold ground? How do we answer that question? Now, when we look at the timeline of SGLT2 inhibitors, as it has already been mentioned, in the year 2016, on seeing the name Empagliflozin in ESC guidelines for heart failure, I was so enticed. I mean, I really wanted this wonder drug, which had shown a greater benefit in patients with heart failure. However, it was not available at an affordable cost at that point in time. Comes 2021, the guidelines have changed. Dapagliflozin was also given an equivalent status along with Empagliflozin. And 2023 focused update, again for patients for CKD and type 2 diabetes mellitus. Both the SGLT2 inhibitors were included in the guidelines. So as the timeline goes, in 2020, as it was already mentioned, Dapagliflozin went off patent in India. And now comes 2025, we have started using Dapagliflozin and we are perfectly happy with the effects of Dapagliflozin. And now Empagliflozin goes off patent in India. Should I switch my patients to Empagliflozin? As a clinician, how do we answer a question? In this era of evidence-based medicine, we will look at evidence. The best evidence comes from randomized control trials, meta-analysis, and systematic review. This is the largest meta-analysis, not largest, but perhaps the most relevant meta-analysis of 5 randomized control trials using data from DELIVER, Emperor Preserved, DAPA-HF, Emperor Reduced, and Soloist WHF, including nearly 22,000 participants from all the trials, and primary endpoint was the occurrence of the composite of cardiovascular death or hospitalization for heart failure. And it was found that all these beneficial effects were consistently observed across all 5 trials. The trials which used Dapagliflozin as well as Empagliflozin, and all subgroups examined. So there is no superiority to claim for Empagliflozin over Dapagliflozin from the meta-analysis of major trials. Now this is another meta-analysis of the impact of SGLT2 inhibitors on kidney outcomes. Around 90,000 participants, SGLT2 inhibitors reduced the risk of kidney disease progression, AKI, cardiovascular death, heart failure hospitalization. Again, equivalent efficacy of Dapagliflozin and Empagliflozin. So looking at a summary of the meta-analysis systematic review of RCT data does not favor one drug over the other. Now coming to real world data. Study 1, this is a study which looked at the comparative outcomes of Empagliflozin and Dapagliflozin in patients with heart failure. This was from a database including around 11,000 patients, and as we can see, Empagliflozin was better than Dapagliflozin in the primary composite outcome of all-cause mortality or hospitalization. But when we actually look at it, there was no difference in all-cause mortality. The problem, the improvement was in terms of hospitalization. But when you actually look at it, the authors say that cause-specific mortality or hospitalization, the cause for hospitalization could not be determined due to database limitations. So the authors themselves say that their results should not be used as an evidence to include Empagliflozin over Dapagliflozin in quadruple therapy for heart failure. This is another study from a Korean group which included 72,000 odd patients, 1.5 lakh person years, and this showed that dapagliflozin was marginally better in terms of heart failure related events. So no significant difference in the composite outcome, but heart failure events were definitely improved by dapagliflozin as compared to empagliflozin. This is a head-to-head comparison of real-world data. This is another study of head-to-head comparison of DAPA and EMPA. They found that compared with empagliflozin, dapagliflozin showed similar risk for most, dapagliflozin showed similar risk for most cardiovascular outcomes. Dapagliflozin had a higher risk of heart failure and a lower risk of genital infections. Again, I was on the verge of switching to empagliflozin. But when we looked at the data, it showed that the higher risk of heart failure for dapagliflozin was seen in patients who were given 5 milligrams of dapagliflozin, which is not the guideline directed dose for heart failure. So the relatively higher risk of heart failure hospitalization was driven by a lower dose of dapagliflozin. So the final conclusion of the study is that dapagliflozin 10 milligrams has similar cardiovascular benefits as empagliflozin. This is another study which again looked at the head-to-head comparison of dapagliflozin and empagliflozin. Nearly 70,000 patients from a Korean database. This looked at the risk of incident atrial fibrillation. So dapagliflozin was found to have a significantly lower risk of incident atrial fibrillation, although there was no major difference in heart failure hospitalization or hypoglycemia. So real world data summary, there is no statistically significant advantage of empagliflozin over dapagliflozin. However, dapagliflozin scores marginally better in the studies done in Asian population in terms of heart failure outcomes and incident atrial fibrillation. I have another worry about empagliflozin because the dosage of 10 and 25 milligrams. This is one study, not sound study, but I would say this study had shown that there was a greater improvement in the surrogate markers with 25 milligrams of empagliflozin. So I'm not very happy about initiating 10 milligrams versus 25 milligrams. So review of evidence, RCT data does not favor empagliflozin over dapagliflozin. Real world data does not show any advantage. Real world data in Asian population has shown favorable outcomes for dapagliflozin over empagliflozin in terms of heart failure outcomes and incident AF. So final verdict, there is no compelling evidence to favor a switch from dapagliflozin to empagliflozin. So I am not switching my patients at the moment from dapagliflozin to empagliflozin pending better evidence. Thank you.